Hi everybody and welcome to the July ISGyP Live Journal Club. Our topics today are gestational trophoblastic disease and germ cell tumours of the ovary. I'm Dr. Deborah Smith. I'm presenting from Brisbane in Australia with my co-hosts and moderators, Dr. Karen Talia from Melbourne, also Australia, and Dr. Rohan Lowry from Brisbane, Australia as well. Now, just before we get into the Journal Club, I'd like to make a small plug for upcoming events from the ISGyP educational team. So there is the podcast, which is available on SoundCloud and is absolutely excellent. There's also slide sessions and webinars from experts in their fields about topics of the day, as well as interesting case presentations also by early career pathologists and trainees. Now, I don't actually have the we don't have the upcoming presenters and topics yet, but these are to look out for in August. Now, if you go to the website that you'll see at the top of the banner here and plug that straight into Google, it'll take you to the point where you can register. If you register, you'll get access to the event live and also have the recording available for the following week. But I would like to recommend joining ISGyP, because if you do so, you can go back into the archives, which is stored from the past many years of presentations. If you are a trainee, membership is free. And if you practice in a developing country, there is a reduced rate. Now, we do like to get trainees and early career pathologists involved. And the two sessions which they're involved in is Journal Club, which is this one, and the interesting case presentation. So if you would like to take part, or if you'd like to encourage one of your trainees to take part, the people to contact, the emails are at the bottom of the page there. Please be aware that there is some change with moderators occurring. And so these emails may change, and refer to the ISGyP website if in doubt. Now, the Journal Club is being presented from both sides of the globe, and we've done that to try and increase the availability for both presenters and attendees to kind of include both time zones. So every second month, it comes from the USA, which is the East team, and that's the third Wednesday of the month. And then every other month, it's on the third Thursday of the month and comes from the East team. As you'll notice, we do have slight alterations in time from time to time. And so you will need to refer to the actual invite on the for the individual session. Now, the schedule for 2023 is this. You can see we're halfway through, but the next topic from the West team is mesenchymal lesions, which is bound to be very interesting. There's a lot going on in that space at the moment. And finally, for the Journal Club, our objective for this is to encourage trainees and early career pathologists to read the literature, to read it objectively and critically evaluate it, and also to provide opportunities for people to present across the globe to a global audience as well. We do provide membership and training, both with the evaluation and also with the presentation. This is an example of the PowerPoint template that we give the presenters to use, which helps keep them on track in terms of evaluating and presenting. Now, finally, a bit of housekeeping. Because this is a live event, we do encourage you to ask questions of our presenters. At the moment, our first presenter is not available for questions, but our second two will be available. And what we'll do is we'll save any questions until all the presentations have been done and have a discussion time at the end. If you would like to ask questions, please use the Q&A function, because we will be monitoring that through the presentation. If you would like to introduce yourself to the other participants, please use the chat function. Now, these are the papers for this month, as you will have seen. So we have intact chorionic vesicles in products of conception. We have molecular analysis of atypical placental site nodules, and also a discussion about cerebellum in ovarian mature teratomas. And now I'd like to introduce you to our presenters. So the first one is Dr. Ming Liang. He's a fifth-year trainee from the National University Hospital in Singapore. Then we will have Dr. Lauren Ray, who is a PGY2 from Massachusetts General Hospital in the United States of America. And finally, Dr. Christy Punnoose, who's a fourth-year trainee from Auckland in New Zealand. Okay, so at this point, we are going to have Dr. Ming Liang Ong's presentation, but it is a pre-recorded presentation. So I will just play that, find it. Okay, get back out of there. Here we are.
Good morning, everyone, and welcome to today's Gynecologic Pathology Journal Club. I am Ming Liang, Registrar from the National University Hospital of Singapore. Today, I will be presenting a very interesting article published in the American Journal of Surgical Pathology that focuses on the normal finding of an intact chorionic vesicle in very early products of conception specimen, which may mimic a molar pregnancy. In this paper, the authors identified a potential pitfall that can arise during microscopic examination of early products of conception, which is the chorionic vesicle. The chorionic vesicle is an early embryonic sac-like structure that surrounds the yolk sac, amnion, and embryo, with villi surrounding it and radiating outwards, which eventually develops into the placenta. We will see more images of this structure later. The authors felt that this was a diagnostic problem worth expounding upon, as 5 of these cases identified in the study were seen as consult cases for a possible molar pregnancy, indicating that there is a degree of morphological overlap that has the potential to cause confusion amongst pathologists. This study is a case series and a descriptive study that included early products of conception with the chorionic vesicle identified. For case selection, the authors identified products of conception specimens containing a chorionic vesicle. For these cases, clinical data, which included maternal age, gestational age, gravidity, history of in vitro fertilization, past medical history, and the nature of the pregnancy, whether it was intrauterine or ectopic, was noted. The authors aggregated the light microscopic features seen, which included the size of the chorionic vesicle, the presence or absence of the implantation site, embryonic tissue, cystins, villus development, villus distribution, villus trophoblastic proliferation, and the presence or absence of abnormal villus morphology and degenerative changes in the villus. In particular, they looked out actively for features that had the potential to mimic a molar pregnancy. P57 immunohistochemistry was performed for all cases, and short tandem repeat genotyping was performed on selected cases. The authors identified 26 cases of early products of conception with a chorionic vesicle. They summarized and emphasized the potential morphological overlap that the chorionic vesicle can have with molar pregnancy and gave practical distinguishing features between both entities. This is a summary table of the 26 cases. Important features are highlighted with red arrows. The gestational age is very early, with a median gestational age of 6 weeks plus 3 days. The majority of women did not undergo reproductive assistance and similarly did not have a prior history of molar pregnancy. While the majority of pregnancies were intrauterine, a proportion of cases occurred as a tubal ectopic. Importantly, more than half of cases were obtained through manual uterine aspiration, which has implications on specimen integrity and the preservation of the chorionic vesicle as an intact structure. This image shows the features of the normal chorionic vesicle. The red box highlights the central portion of the complete intact chorionic vesicle, which contains the embryo, the amnion, and the yolk sac. Surrounding this in the blue arrow is ramifying primary, secondary, and occasional tertiary villi that covers the entire surface of the chorionic vesicle and which ultimately forms the placenta. The individual villi show polarized trophoblastic proliferation, which we will see in a close-up image later. This composite image highlights the morphological similarities that the chorionic vesicle may have with a molar pregnancy. The red arrow in image A shows that these structures also have a prominent central cavitation, which can resemble the cistern of a complete mole, especially if the central chorionic vesicle with its embryo, amnion, and yolk sac is displaced. In images C and D, highlighted by the blue arrows, the nature of the circumferential radiating villi and the proliferation emanating from the tips of the radiating villi may cause confusion with a complete mole. The authors also highlight several additional features that may be confused with a molar pregnancy. These include stroma eukaryosis and blue-gray myxoid appearance of the villus matrix as indicated by the red arrow, which mimics the changes seen in an early molar pregnancy. The blue arrow shows villus alterations with irregular protrusions resembling animal-like shapes as can be seen in a partial mole. The yellow arrow highlights invaginations with pseudo-inclusions also mimicking features seen in a partial mole. The green arrows seen at the bottom show that there is trophoblastic proliferation, but this is limited to the tips of the individual villi, that is to say, the trophoblastic proliferation is polarized. The authors also point out several distinguishing features that allow distinction from a molar pregnancy. First, the cistern is not a feature in very early complete moles, which one would expect to encounter in such an early gestational age. Furthermore, attention to the polarized nature of the trophoblastic proliferation occurring only at the tips of the villi, despite the circumferential positioning of the villi around the chorionic vesicle, together with the realization that very early complete moles do not exhibit exuberant circumferential trophoblastic hyperplasia, allows distinction on this point. Furthermore, as seen in this image panel, degenerative changes in the villus trophoblast and paravillus fibrin deposition, which are common features seen in miscarried specimens, are histological features that are not usually seen in a complete mole. Additionally, the blue arrow in panel D highlights the lace-like trophoblastic proliferation that can be seen occasionally in molar pregnancy, accentuating the mimicry between both entities. This summary table, given by the authors, details the differences between the following entities. Of note is the early gestational age, the presence of embryonic tissue, non-polarized trophoblastic proliferation, and the presence of degenerative changes in the villi that is key to recognition. This is a summary slide of what I have mentioned earlier. In addition, P57 immunohistochemistry was intact in the villus trophoblast, stroma cells, and intervillus trophoblasts in all cases. The two cases on which short tandem repeat genotyping was performed also showed a normal biparental diplot phenotype. Moving on to discussion. This paper highlighted a rarely described normal structure in embryology that is a potential pitfall that may be confused with molar pregnancy. The authors speculate several reasons why this entity may not be commonly encountered in POC specimens. First, The chorionic vesicle appears very early on in pregnancy, in which the pregnancy itself may not be recognized by the woman, with spontaneous miscarriage resulting only in minor uterine bleeding that may be dismissed and that does not lead to the woman presenting to a doctor. The chorionic vesicle itself may have been dislodged or shed from implantation site prior to any procedure, and the procedure itself could have mechanically disrupted the chorionic vesicle, resulting in it being unable to be identified in POC specimens. The authors speculate that this finding of the chorionic vesicle may be more common in centers offering in vitro fertilization, as these centers are enriched in women who may present with very early miscarriage that is quickly detected. The authors emphasize the correlation with actual gestational age and confirming the diagnosis with p57 immunohistochemistry and short tandem repeat genotyping is essential. Strengths and area of improvement for the paper. This paper brings to light something that we do not normally see or actively think about in routine practice, with real potential for misinterpretation for a molar pregnancy. It provides a detailed comparison of morphological features that may be used to separate it from a molar pregnancy. It would have been interesting to have performed a retrospective review of cases signed up as focal molar pregnancy, suspicious molar pregnancy, or early molar pregnancy to see if any of these cases actually represented a chorionic vesicle, especially for cases upon which no additional investigations were performed. Applications of this paper. This paper is very applicable to practicing surgical pathologists who see POC specimens regularly. It raises awareness of this uncommon entity and serves to remind pathologists to pay greater attention when examining products of conception specimens from early gestational age, especially if the center where the pathologist practices at offers in vitro fertilization. There should also be a lower threshold in performing p57 immunohistochemical staining in such cases. In addition, there may be a case for experts to include a section on the chorionic vesicle under the chapter of gestational trophoblastic disease if they are writing a textbook to raise awareness of this entity and its potential to mimic a molar pregnancy. I have reached the end of my presentation. Thank you very much for your time.
Okay. So thank you very much to Dr. Ming Liang, and it's a pity that he hasn't been able to join us. But that was a great presentation, and I appreciate the fact that he has given us the recording. Now, our next presenter is going to be Dr. Lauren Ray from USA. Lauren, are you able to share your screen?
Yes, let me pull it up.
Yeah, thank you.
Oh, I think you need to stop sharing before I can
Stop
take
sharing.
over.
Yes. Yeah. There we are.
Perfect. Okay. Can you see everything okay?
Yes, we can. Thanks.
Perfect. All right. Well, it's a pleasure to be here with everyone this morning, your time, but I must admit it is 8 p.m. on the 19th over in Boston, Massachusetts, which is where I am located. So I am a second year PGY2 resident at MGH, and I'm really excited to take part in this. One, because I'm really enjoy both gyne and OB pathology and wanted an opportunity to share some of the updated literature with everyone, but also I'm really passionate about this patient population. And I think that the article that I have to share with you today is really impactful in moving forward in the field of gyne pathology. And so what I'm going to be discussing today is a paper that was published in Modern Pathology earlier this year that focused on molecularly analyzing chorionic-type intermediate trophoblastic lesions, particularly looking at atypical placental site nodules and where that may fall on a spectrum of disease involving placental site nodules or PSNs all the way to epithelioid trophoblastic tumors or ETTs. So this group that's based out of France from the Hospice Civils de Lyon by Jeremie et al. Is really interesting digging into the molecular aspects of these lesions. So to start, I want to go back over just some of the basics, help refresh everyone on what we'll be discussing today. So as we know, intermediate trophoblast have two subpopulations from which we typically see lesions in arising malignancies. One, the implantation site, but secondly, the chorionic-type trophoblast, which is what we'll be focusing on today. So historically, we've known about a PSN or the benign version, as well as an ETT or the malignant version. But the WHO back in 2020 introduced a new entity named the atypical placental site nodule that is thought to be somewhere on a spectrum of disease between these two entities, or a putative ETT precursor of sorts. But with that being said, really the diagnostic criteria has been difficult to feel confident about because it's somewhere in between and we haven't fully understood the entity until this particular paper was released. We do know that the atypical placental site nodule tends to have more malignant potential than a PSN does, but of course doesn't fully fit into the scary ETT malignancy category. And as a result of that, it's been unclear how we should manage these patients. In particular, it's been difficult to one, ensure that we aren't overdiagnosing or underdiagnosing. And then secondly, it's been difficult to know how far we should take the management of these cases. And so as a result, this group, Jeremie et al., had the goals of first helping to further define this entity, this APSN, and where exactly it may fall on the spectrum of disease, and if we can classify it that way. To do this, they worked to correlate transcriptomic characteristics of these entities to their histologic type. And then lastly, they had this ultimate goal of being able to provide molecular tools for us to differentiate these entities more concretely and with more confidence. So to do this, they retrospectively selected a bunch of trophoblastic tumors from their archives between the years of 2012 and 2021 to pick out the APSNs. Since this is a newer entity, they ended up using the qualifications of a higher Ki67, so more mitotic activity, a little bit larger in size than a typical PSN, and then having at least one of these more malignant potential aspects or characters, such as atypia, increased cellularity, or any mitoses. And then ultimately, they were able to find 8 PSNs, 7 ETTs, and 7 APSNs, which I think is pretty impressive given that these really aren't super common lesions. And so that's what they were working with, and ultimately provided or performed all of their data analysis using a p-value of 0.05. So keep that in mind moving forward. So how they actually compared these three entities involved 4 different methods. First, they really delved into the details of both the clinical presentation and the histologic presentation with the hopes of maybe being able to find some common themes and kind of going back to the roots of pathology in these entities and what we know. Then next, they looked at IHC, so did 4 different stains, P63, HPL, cyclin E, which was evaluated utilizing an H-score, and Ki67. The latter 2 we'll go into more detail of later. And then they also performed transcriptomic analysis utilizing a nanostring method, which evaluates 760 genes total over 13 different cancer pathways. And then lastly, they also performed RNA sequencing to evaluate for a fusion, the LPCAT1 TERT fusion, that it has historically been associated with ETTs. So looking at their results of the clinical presentation, of note during my presentation, you'll find a bunch of tables that are not in the paper itself, but they are rather adaptations that I've formed just to be able to present this information in a more concise manner. But as you can see, a lot of the clinical presentation among these 3 entities is pretty much the same across the board. There's not any one thing that clinicians can look out for to be able to pick which entity it is. Aside from the size, which is suggestive and supportive of that spectrum of disease I was mentioning, where a PSN tends to be a little bit smaller, around 3.8 millimeters, and then ETT averaging in this cohort at least 25 millimeters. So it is supportive of information that we have historically accepted and known. And then moving forward to the histologic features that they noted. Of course, we have the images at the bottom, but looking up at the top, again, nothing very clean cut in terms of being able to look at an H&E and make it an accurate and comfortable diagnosis, particularly as you see between the APSN and the ETT, there's a lot of similarity here. And naturally, we know how aggressive ETTs can be, and so you don't want to miss that, but at the same time, you don't want to put a patient through unnecessary treatment. And call an APSN an ETT. So this did illuminate one of the issues that we have. And then I also wanted to highlight the mitoses that they counted. So again, just following with that theme of a spectrum of disease, going from no mites seen in PSNs on average up to 4.11 per high-powered field in ETTs. Now, the IHC results is where things start to really get interesting. So obviously the P63 and the HPL didn't show any differences, but the Ki67 again helped to support this spectrum of disease, which is a natural correlation to the mitotic activity that we noted on the previous slide. But what I really want to highlight is the cyclin E H score. So while you can see that there was some increase between the PSN to the ETT, there was no significant difference between the three of these entities. And I want to highlight that they did evaluate utilizing an H score, which is not one of my favorite methods, just purely out of the point that it is intensity of staining with a combination of how many cells. But with that being said, it is understandable that it's difficult to keep these evaluations standardized otherwise. So something to keep in mind, particularly in the context of previously understanding that cyclin E tended to be increased in ETTs, but the results here, of course, don't support that as a statistically significant difference. Then we move on to the molecular aspect. So LPCat1 TERT fusion was analyzed, as I mentioned, and was consistent with what we have accepted and known in the past, where ETTs tend to exhibit this fusion in about 33% of cases. And again, this is one ETT out of 7, so roughly that percentage. And then the transcriptomic analysis looked at PSNs versus APSNs, and then APSNs versus ETTs. So first, looking at the PSN versus APSN, there were 7 differentially expressed genes out of the 760 on the nanostring panel. In particular, CCL19 was increased in APSNs and EpCAM was decreased in comparison to PSNs, and there was a statistical significance in the difference there. But with this being said, only having 7 differentially expressed genes did not allow for differentiation among hierarchical clustering that was performed. Looking at the APSN versus an ETT, there were upwards of 80 differentially expressed genes, so obviously significantly more, and of particular importance were the CCNE1 expression that was increased in ETTs, and then the KIR2DL3 was decreased. But what do we do with all this information? I wasn't quite sure until I flipped the page and noted their multidimensional scaling plot that I think perfectly illustrates the combination of all this information and demonstrates the relationship between these 3 entities. So as you can see here in the red orange is the ETT circled and over off on its side. So essentially a distinct entity from the others, whereas the APSN and the PSN do have some form of overlap. So this image alone, combining all of the information, really is suggestive that the APSN tends to lean more towards the side of a PSN rather than an ETT based off of molecular data. So I want to break down what this all means in terms of supporting what we currently have accepted as true, what it could challenge as what we currently accept, and then what are new findings that this brings to the table. So in terms of support, as I mentioned, it does continue to support the reliance upon LPCat1 TERT fusions for ETTs. If it is there, you can feel confident in your diagnosis. It also helps with this understanding of a continuum of morphology, again, the spectrum of disease, supporting changes in cellularity, atypia, and mitotic activity in almost a stepwise fashion from PSN to APSN to ETT. And then this is further supported by the Ki-67 increases that we saw in the data here. Some challenges that this journal or this paper presents is that cyclin E may not be differentially expressed, at least not as reliably as we may have thought in the past between these groups. So something to keep in mind when you're evaluating them, and particularly if you're utilizing cyclin E. And then the new findings that are presented to the table are one gene expression differentiation between ETT and APSN, but not necessarily between APSN and PSN, as we noted in the overlap on the MDS plot. It also helps encourage this thought that APSN is a transitional stage on the spectrum of disease. And then ultimately, these new findings help to explain why in the past it's been difficult to, off of H&E and histology, morphology alone, make these diagnoses, is because there is a lot of overlap. They're so similar. And so at least now we can have a better understanding and a better global picture of how these entities relate. Some strengths that I noted of this study are, one, the amount of effort that this group put into ensuring that the original diagnoses were correct before performing said molecular analysis. They had a senior pathologist independently review all of these cases and formulate a diagnosis. Additionally, they took great caution in analyzing mitoses versus karyorrhexis, which in these cases is particularly important because even one mitotic or one mite being noted can push you into the APSN category. Additionally, I noted how great they were about including recent literature, which I know is very hard to do in these entities that are continuing to develop in terms of our understanding. And then also I was really impressed with their utilization of the multidimensional scaling plot and the way that they presented all of their transcriptomic data. But with that being said, on the flip side, there's always areas of improvement with any project that is performed. One, of course, we can always increase power, increase case volume, particularly in this group. It is difficult because they're rare entities. But with that being said, obviously, would be greater to have a higher cohort. And also including other geographic regions, as all of these cases were taken from this group in France. Another piece of improvement I mentioned earlier is the H-score, particularly given that the cyclin E results here are not consistent with what we've previously accepted. It does make me think that perhaps it would be beneficial to evaluate cyclin E in a different manner rather than just the H-score. And then also I noted that though ETTs don't always show the fusion, in those that don't, sometimes there is a TERT amplification, and that was not looked at in this particular study. And I think that is something that would be worth evaluating moving forward. Some immediate application of this, obviously it's a very useful piece of research. So one, it can help with triaging these PSNs and these APSNs to help create a more concrete diagnosis to move forward with patient management. Second of all, it can help us kind of throw up our red flags when looking at cyclin E. I'm not saying it couldn't still be utilized. It does show some increase in this study as well, though it wasn't statistically significant. It's worth noting that maybe we should use more caution before relying upon the cyclin E IHC. And then lastly, some immediate application is just continuing to utilize the Ki-67 because that, as well as mitotic activity, does tend to correlate with the spectrum of disease very well and very reliably. Moving forward, there's a lot of work still to be done in this area of the field with the understanding these entities. One, we could help move forward with validation of the ETT transcriptomal signature that was noted here. It was just performed with an in-house panel. So moving forward, it would be helpful to have that validation elsewhere. I think it would also be helpful to have more accessible triaging methods because I recognize that not everywhere, and probably not even everyone listening here, has access to these fusion panels and can look at the molecular profile of these entities. So it'd be nice if in the future we can have an IHC that corresponds as well. Also, I think it would be nice to look more at APSN adverse outcomes because there's currently not much data looking at how these patients tend to perform, or how the cancer tends to perform if it develops in these patients later. And then also clinical management, kind of segueing off of that, obviously being able to further study what is the best management strategy for these different entities is something worthwhile to study in the future. So with that being said, I'd like to thank Dr. Rohan, he was one of my mentors, as well as Dr. Drusilla Roberts and Dr. Aliva, who are here at MGH and within the OB-GYN subspecialty here, for all of their mentorship and their help with this. And my references here, it's the paper itself, as well as images that were created using BioRender for this presentation. So thank you for your attention.
Thank you very much, Lauren. That's an excellent presentation. Well done. And I'm just going to switch it across now to Christy for your presentation, and then we'll do questions at the end.
Sounds good.
Christy, can you share your screen? Yeah.
Can you see my screen?
Not yet, not on my screen.
Yes, I can see it.
You can see it? Oh.
Sounds good. Okay, so hi everyone. I'm Christy, a fourth-year AP trainee from Auckland, New Zealand. Today I'll be discussing a case report on well-developed cerebellum in an ovarian mature teratoma from a pregnant female, published in the International Journal of Gynae Pathology in 2021. So mature teratomas are germ cell tumors that are histologically defined by the presence of mature tissues from two or more embryological germ cell layers, namely ectoderm, mesoderm, or endoderm. These can occur at any age, but are common among reproductive aged women. These tumors account to almost 20% of all ovarian neoplasms. Teratoma elements are typically arranged in a relatively haphazard manner, although well-organized embryonic organ structures, including mature bowel, may be seen. Up to half of mature teratomas may have neuroectodermal structures. However, it is very rare to come across well-organized brainstem and cerebellum in these neoplasms. So going quickly over the main differences between a mature and an immature teratoma. Mature teratoma is composed of mature tissues, which may be mature ectoderm derivative, for example, the squamous epithelium is seen here, or a neuroectodermal derivative with neuroglial tissue. The immature teratoma is by definition composed of immature embryonic type tissue, which generally corresponds to between 2 to 8 weeks, along with variable amounts of mature tissue. Tissues corresponding to fetal tissue that is more than 8 weeks do not qualify. All elements of germ cell layers are usually present in an immature teratoma. However, the ectoderm and mesodermal components predominate, and it is in these components that immaturity is most evident. Grading is performed only on the neuroectodermal elements. The tubules and rosettes in an immature teratoma that can be seen in these pictures are generally composed of mitotically active hyperchromatic cells. According to the WHO book, the neuroepithelial elements are required to call it an immature teratoma, and grading is performed based on the size of these elements. This is a single case report that describes the most well-organized cerebellar structure reported in a mature cystic teratoma, and the first such case seen in a pregnant female. This article highlights the remarkable developmental plasticity of teratoma cells to generate well-ordered neural structures through local patterning and tissue signaling. The authors have reviewed the literature and have provided discussion around 2 prior cases with a highly organized cerebellar differentiation, although not to the level of maturity seen in this case. Before we get into the details of the case report, let us just have a quick refresher of the neuroanatomy, focusing on the posterior fossa. The posterior fossa structures include the cerebellum and brainstem, along with the cranial nerve nuclei. The vermis is the midline portion that connects both the cerebellar hemispheres. The first picture shows the sagittal section of the brain with the cerebral hemisphere, the cerebellum, and the brainstem showing the pons and the medulla. The second picture shows an inferior view of the brain, including the cerebellar hemispheres, the vermis through the middle, the pons, and the medulla. These pictures display the cerebellar cortex layers. The cerebellum has 3 layers. If we focus on the second picture, located between the surface pia mater on the top and the white matter of the cerebellar medulla at the bottom, we have the outer hypocellular molecular layer. Middle, we have the Purkinje cell layer, and then the inner hypercellular granular cell layer. Here, the first picture shows a few sites of choroid plexus in the brain, which is responsible for CSF production. And it's present at the roof of the third ventricle, depicted by the blue arrow, and the fourth ventricle, depicted by the thick arrow. The second picture shows a high power view of the choroid plexus, as depicted by the thick arrow, and the epidermal cells covering the surface of the ventricle, as shown by the thin arrow. The case described is of a 38-year-old pregnant female who had an incidental left adnexal cyst with a maximum dimension of just over 3 centimeters, picked up on a routine prenatal ultrasound conducted at 6 weeks. Radiology features were in keeping with a mature cystic teratoma with no concerning features. Patient went on to carry a full-term pregnancy and underwent a C-section at 41 weeks with the delivery of a healthy newborn. Following the delivery of the baby and placenta, examination of the pelvic cavity revealed the adnexal mass attached to the left ovary. The mass was resected with the preservation of the ovary and then sent for histology. Examination of the ovarian mass revealed a larger cystic cavity composed of hair and sebaceous material, with a smaller cyst composed of symmetrical lobes and foliation suggestive of a cerebellum. The opposing surface was smooth with an appearance of white matter or brainstem-like tissue. The lining was smooth and consistent with dura, and the fluid surrounding the cerebellar structure was light yellow and resembled CSF. Picture A and B shows the lateral foliated lobes with a well-differentiated cerebellar cortex with appropriated oriented layering composed of outer molecular, central Purkinje, internal granular cell layer with a central white matter. Notably, the external granular cell layer, which is normally present until 1 year postnatal age, was absent. Therefore, this is suggestive of differentiation corresponding to more than 1 year of developmental age. The molecular layer in this case was of unremarkable thickness, and the Purkinje cell layer showed rare hypereosinophilic neurons suggestive of focal hypoxia. The internal granular cell layer was well populated by granular neurons. Picture C and D shows the central lobe of the cerebellum-like structure which showed a vermis-like differentiation. Picture E shows meningeal cell layers surrounding the cerebellar tissue. Picture F shows an adjacent ependymal-lined structure in keeping with choroid plexus and possible CSF suggestive of ventricular differentiation. Picture E shows the brainstem-like tissue abruptly terminating in the dermoid cyst wall in the region of the fibroadipose tissue, bronchial and skin structures. Picture F shows peripheral nerve-like structure with Schwann cells possibly suggestive of an abortive cranial nerve differentiation. Here we see Luxol fast blue and Crescel violet stains. In picture A, the cerebellar white matter shows a positively stained, well-myelinated appearance, which is consistent with a mature developmental age of more than 6 months. Compact vesicular bundles of myelinated axonal fibers in the tissue adjacent to the cerebellum, suggestive of brainstem development, is depicted in picture B. Interspersed neurons were highlighted in picture C. In the discussion, it was evident that the histological assessment supported the gross assessment of highly organized posterior fossa structures. The cerebellar structure was arranged into folia with appropriately oriented layers. This case also shows that a notable degree of cerebellar development can be seen in an ectopic setting in the absence of other systemic cues. However, the cells may have functional abnormalities in spite of a high degree of differentiation. It was also noted that the teratoma grew by over 8 millimeters during pregnancy, which raised the possibility of stimulation by pregnancy hormones. However, in spite of more and more incidental adnexal masses picked up with the advancement of prenatal imaging, this degree of development has not yet been reported in pregnancy, and therefore the authors believe it to be unlikely for pregnancy to lead to hyperdevelopment of a mature teratoma. The authors make comparison to 2 prior case reports with well-formed cerebellar structures. A few differences were noted, including a better differentiation on gross and histology here. Cerebellar dysmorphia was noted focally in the vermis-like region in this case, in comparison to the widespread significant areas of dysmorphia in others. As mentioned earlier, the maturity was higher due to the presence of external granular layer, which were absent in the other cases. This case displays the remarkable developmental plasticity of teratomatous tumors to form organized and mature neuroanatomic structures. There are a few more case reports and articles discussing cerebellar differentiation in teratomas, of which I shall mention 2 articles. The first article expands on 6 teratomas and highlights the diagnostic challenges one faces to distinguish immature from mature neuroepithelial elements, which I will touch upon in the coming slides. The second is a case report, which was published in 2022, where they have discussed a non-pregnant female presenting with abdominal pain with a subsequent diagnosis of an ovarian mature teratoma, composed of well-organized cerebellar differentiation. Here they mention about 22 cases having been reported with organized cerebellar differentiation, but there is no detailed comparison of these cases mentioned in their discussion. Overall, the background and summary provided a baseline of familiarity to the condition and was representative of the case. The clinical course was presented appropriately. Relevant review of literature, including a few previously reported cases with cerebellar differentiation, were discussed with adequate comparison. This case report gives us an insight into the unique neural development within teratomas. As per the article, the review of literature highlighted 2 cases with highly organized cerebellar differentiation. However, there are a few more cases, as we have discussed earlier. One of the pitfalls in teratomas is mistaking mature cerebellar tissue or other elements, such as ependymal lining, with immature neuroepithelium. Generally, if cerebellar architecture is well developed with a characteristic folial architecture, it may be less challenging. However, it may be difficult to recognize less organized cerebellar tissue, particularly areas resembling the highly cellular granular cell layer, which may be interpreted as immature neuroepithelium. The first picture shows a high mag of external granular cell layer on the left, showing immature cytological appearance and an occasional mitotic figure as shown by the arrow. The other cortex layers are present sequentially towards the right of the image. Although this may cause concern in view of the immature and proliferative appearance, if we appreciate the preserved microanatomic context, it is helpful in getting to the correct diagnosis. Pictures A and B show immature neuroepithelium with prominent tubules and rosettes in figure A. Figure B shows a high mag with a rosette on the upper left, merging with neuroglial tissue and some necrosis in the lower right. External granular cell layer, which is present during the fetal development, includes the immature proliferative neurons. These gradually lose mitotic activity and migrate towards the Purkinje and inner granular cell layers. The external granular cell layer therefore shows high Ki67 and can be misinterpreted as genuine immature elements if their specific differentiation is not appreciated. The most helpful feature to avoid this pitfall is the recognition of a preserved cerebellar microanatomy, which differs from the haphazardly arranged cellular neuroepithelial tubules seen in immature teratoma. Ki67 can show a reduction as we move away from the external granular cell layer towards the Purkinje layer, as shown in picture D. This helps to highlight the zonal pattern of normal development of cerebellar tissue. SOX2, SAL4, and nuclear OCT3/4 expression may be positive with immature teratomas, which could help differentiate from mature elements. In conclusion, finding cerebellar tissue can pose a diagnostic challenge to the pathologist due to its rarity and morphological appearances, and can make it difficult to differentiate from an immature teratoma. It is helpful to check for the preserved cerebellar microanatomy to diagnose a mature teratoma. Ancillary studies may be helpful. However, there are gray areas, and neural elements in mature teratoma can show microanatomic disorganization and expression of immature neural markers. Therefore, the assessment of immaturity may be more ambiguous than considered in routine practice. It is also possible for well-developed cerebellum to coexist with immature elements. This emphasizes that a thorough sampling of ovarian teratoma is important. It would also be of interest to assess the effect of pregnancy hormones, if any, on the growth of ovarian mature teratomas, particularly those that are picked up early during prenatal ultrasounds, which are planned to be managed conservatively, secondary to the smaller size and lesser risk of torsion. Thank you. That concludes my presentation.
Thank you very much, Christy. And I'm just going to go back and share my screen again. And if all the presenters and moderators, if you can turn your videos on for we've got about 5 minutes left for Q&A. Okay. So, Lauren, actually, Christy and Lauren, those were both excellent presentations. I learned a lot. Very fantastic summarizing of the article, but also drawing in information from elsewhere. So I've just got a couple of questions for you. First, we'll start with you, Lauren.
Okay.
And that is, this was a good paper. I struggle with this diagnosis. I felt better when I saw they reclassified one of their 8 atypical placental site nodules, because, you know, that's 8 out of 10 years from a referral center. So that did make me feel better about my difficulties with it. And I think you went into the reasons of that really well. The question I have for you is, how are the atypical placental site nodules handled clinically where you work? Do you know the answer? You know, what does this mean for the woman?
So after reading this, a group of us actually were curious and reached out to our gynocs here to see what they typically advise patients to do. So most classically, they recommend hysterectomy right off the bat, because studies that they have read have shown that upwards of 15% can subsequently turn into an ETT. And so the safest option is just to opt for a hysterectomy. With that being said, for women who are still of childbearing age and desire fertility, what they typically recommend here is having a hysterectomy at least within 4 years after the diagnosis of an APSN, because most classically, if a transformation is going to occur, then it would be within, or I guess the worst prognosis of a transformation would be after 4 years from their last pregnancy. So what they recommend is to try and finish their childbearing within 4 years of the diagnosis and then have a subsequent hysterectomy.
Yeah, okay, so that's quite a significant outcome from an entity that's quite hard to diagnose. So in view of that, do you have access to things like cyclin E? We certainly don't. We are just morphology and maybe the dual Ki67 cytokeratin stains.
So we do. I think that in cases that are challenging like this, what we would probably pursue is the whole panel, just because we're fortunate enough to have access to all of that. But with that being said, I personally, after reading and studying this, would put Ki67 at a higher weight in terms of deciding where to classify it than I would the cyclin E, particularly with the discrepancy found in this paper versus what we've classically relied upon. But of course, it seems like if we can get a fusion panel, that would be gold standard if positive, for feeling more confident in recommending, you know, the treatment that we know is associated with an ETT and an APSN. So yes, I think that Ki67 is most important, but cyclin E, of course, would be good to look at and have as a piece of the puzzle if available.
Yeah, it certainly would help, especially when the morphology is so difficult. Yeah. Thank you. Christy, a question for you now as well, and thank you for your presentation. It is one of those areas which does become difficult in teratomas, having cerebella or immature looking neural tissue there. So I appreciated your sort of broadening out the paper to include a broader discussion of that. And I think one of the things you said right at the end was about sampling. And I just wondered, how much do you sample? I sometimes find that there's sort of a feeling like, it's nothing, take a couple of blocks. Do you have recommended routine sampling? Because clearly if we don't sample, we don't find things.
Yeah, so with sampling, we've been told to target the solid areas as much as possible. And if it's a smaller portion, we sort of go with the entire solid area. But if it is a bigger area, then we go 1 block per centimeter, and obviously take some background cyst wall as well. And then if we do find something interesting on histology, which sort of is concerning for an immature element, then we go back to the specimen and we put more through.
That sounds similar to the protocol we run here. Have you actually seen cerebellar tissue in teratoma? Is this a thing you've had to work through?
I haven't actually in real life.
Yeah. What about immature teratoma? Because they themselves are not common. I think what's hard about these entities is they're not common, so you don't get much experience in looking at them. You're always just looking for them, but you don't necessarily see them.
Yeah, it was brought up in one of the interesting cases, but I haven't reported it myself, which had some immature neuroepithelial elements. And I don't think they did any ancillary studies, but from my understanding, you can do a key 67 to highlight the proliferative areas. But the other stains that were mentioned in other articles, the OCT3/4, the SOX2 and things, were not something that we do here, as far as I know.
Okay, is that because you don't have them?
As far as I know, we don't have SOX2, but we do have the germ cell markers like SAL4 and things. But yeah. I guess it's just the experience of it being positive in immature teratomas. I guess the gynae pathologists here, they just show it around and get some understanding on whether it is an immature neuroepithelial element. And sometimes, I guess, even include a neuropathologist if necessary.
Yeah, no, that's fair enough. We have about 1 minute to go. Do any of the other hosts, moderators, want to say anything or ask questions? Okay, in that case, I'm just going to say hi to Yen, who we were going to say hi to at the beginning. Sorry, I didn't see you there until we were partway through.
No, it's all right.
So welcome to the Journal Club team. It's lovely to see you.
Nice to see you too.
Thank you. And I think we are smack on the hour of 11 o'clock here. So thank you very much for those who've attended. I hope you've enjoyed the presentations. I certainly did. Thank you very much to our presenters who did a fantastic job. And we look forward to seeing everybody again in 2 months.